Thank you for joining us for another episode of 340 Banter. Today we're joined by Matthew Krah, a Senior Solutions Engagement Director at Verity Solutions, a 340B TPA. In today's episode, we discuss challenges and tips for success in navigating the pharmacy and 340B aspects of UDS reporting, which is required annually for health centers. All right, let's talk UDS today. So Uniform Data Systems, the annual reporting that health centers have to provide on their finances, their demographics of their patients and payers, as well as the quality of care metrics. So Matt, I know that you have done a lot of work on helping health centers to be able to pull this data around the pharmacy piece and the 340B program piece, which is a very small portion, but often a very overlooked portion of the UDS. Can you talk to us a little about that journey?
I can, yeah. So I started off with my hospital's health network I worked for. They were exploring feasibility of changing some of our primary care locations into lookalikes. And actually, I was probably one of the only people that actually read the manual. So that's usually a good start. So that was my first exposure probably in 2017.
Did you fall asleep reading it a lot? You use it as
real riveting.
No, I mean, so like when you've lived in pharmacy as long as I have, like not to age myself, but I think we're going to like almost 20 years now. It's kind of like, all I know, and it does get me excited. And I like knowing the full spectrum of healthcare, right? And not just like our little vacuum that we all work in every day. So it's always exciting to learn something new. But then I came over to Verity. So Verity, as most of you know, is a TPA. So we provide full service management for owned pharmacies, hospitals, contract pharmacies, referral capture, everything. And I was scrolling on LinkedIn one night, and Michael Gonzalez, the CFO of FQHC, 340B compliance, was pounding his fist that TPAs better get their act together.
As one does on LinkedIn.
Right. There's no better place in social media to get your point across that we need to start doing a UDS report. So I'm like, okay, well, what's really needed in a UDS report from a TPA? So I went back through the manual again, one of my partners and I at Verity, and we said, okay, I think we need to do this. So we brought it up to our CEO at the time to get support. And basically the answer we got was, well, yeah, of course we've got to do this. Our customers don't pay us to say no. Okay, great. So then you have that conversation with the developers. Okay, I need a UDS report. They took it literally, meaning that we thought that we needed from start to finish a full UDS report created.
Boy. And there's so much there that you don't even have access to.
Correct. And that was, I guess, an amateur mistake on my part, very new to the software world and dealing with developers and product managers that don't work in pharmacy.
Amelia Bedelia.
Yeah.
I don't know if you ever had to read those books, but you ask a question or make a request, and technically they follow through on it.
Yeah, literally.
Yes. Yeah. I'm married to a developer, and I have to live this life all the time and remember that I am married to Amelia Bedelia.
And then we said, okay, guys, hold on, step back. It is not the whole UDS report. So there was a sigh of relief there, but there was still some roadblocks that we had to work through. So we know we only need table 8 and 9. And we're also limited in the data that we have, even as the TPA. So that was one of the things that I spent some time talking to Michael about. Like, yeah, okay, the TPA should have all this data, but we're also relying on what the pharmacy sends us, right? So
running into many of the same challenges that the health centers are having, except they probably don't have the staff to even know what they're doing with that data in the first place.
And I think a lot of times they don't understand entirely what the reports mean from their TPA. So understanding those what each column is helpful in that. So it's helpful coming from that TPA side, but it creates some challenges.
And I think it creates more challenges too for customers that have a mixed bag of a software stack, right? So we know that some of the chain pharmacies force their clients to use their own software stack. So I can have a pre-baked report that's awesome and everyone loves, but does that mean that the other vendors are going to have that? So that also puts the health center kind of in this, challenging predicament of how do you get the right data to upload to
Blending
not,
all that together
yep,
and making apples and oranges
to
makes
not
sense.
trip one of those blip alerts. And another piece to it is if you're a closed door pharmacy in your health center and you're not using a TPA, well, if the data is not coming into our system, I can't help you create the report. Working through some of those challenges, learning as
Within
we
those
go.
challenges, what data did you find, or do you still find the most challenging to pull in or to incorporate?
Well, the most challenging piece was the payer types, right? So I know that this probably isn't a shock to
That's
anybody.
hard from the entity-owned side as well.
Anybody, right?
Yeah.
So there's no publicly available database of Medicare, BIN, PCN, and group combinations. We've got Medicaid figured out, right? We've all been doing that for a long time, but even that's kind of tribal knowledge as well. There's no real, solid database. Some states do a better job than others, of course, right? But there's still not a database. And then, how do you determine what's a Medicare, what's a commercial? So this is one of those.
Or the bane of everyone's existence, the Medi plans.
Yes, yes. It's a challenge for us as the vendor. It's a challenge for the CEs, and it wasn't a cheap hurdle to get over either. And I often say that there's price and there's cost when it comes to shopping for TPA. So Verity is never going to be the lowest price vendor, and that's really not our intention. What our intention is to bring a high quality solution and really drive that value. And you get that with the amount of resources that we put into developing this report. So we had to go and find a couple different vendors that warehouse that data and categorize it in Medicare, commercial, Medicaid. And we spent a lot of money to get that. It was not a cheap resource.
Yeah, and working with Michael, one thing I noticed on the UDS when I came over, because I do a lot on the entity-owned side, is that pharmacists and finance people have different languages. So being able to blend those and understand what each is talking to is really challenging. I think that's probably something you guys have dealt with as well, is understanding what those fields mean and interpreting them to your clients.
Yep, definitely. And we have that great exportable summary table that you can literally copy and paste. And for that reason of everyone having their own interpretations, we actually give you the raw data behind that summary tab. So if you don't like something in our summary, you've got all that backing data that you can do and maybe align that up better with your other TPA partners that you have to use, again, to avoid tripping any of those errors when you submit your UDS report.
So I know one of the challenges for health centers when the TPA that they use doesn't have the right information or the information that they need, or when they're pulling from perhaps independent pharmacy partners in doing the UDS calculations and reporting, there's some pricing elements in there that can be more challenging to get. I don't know, Logan, if you kind of want to explain what the challenge is, and then maybe Matt, you can share with us what you guys do.
In the UDS, you're supposed to put your actual charge, which is generally your usual and customary charge, which those of us in the pharmacy world know is a fictitious number that never gets paid. But you're supposed to show the change from usual and customary down to what's actually paid, and that net is an adjustment. And with some of the pharmacies, I know that getting that usual and customary is challenging and sometimes impossible. So, a lot of times you have to figure out a surrogate. So, what did you guys do at Verity to really overcome those situations?
So we use Medispan as our database for all NDCs, and Medispan has a WAC price. So we came up with a float off that Medispan WAC to be an AWP like pricing, and that's what we've used. So the challenge is if we have switch data from a pharmacy, most likely we're getting the usual and customary from the pharmacy. So like very rarely do we have an independent pharmacy that sends us data directly. And we could even work around that because in our data spec, we do say there is a field for usual and customary for them to submit that. The real challenge comes from the specialty pharmacies. So, I don't know if a lot of our audience really knows kind of behind the scenes how the TPAs get the data from the specialty pharmacies, but they're doing a lot of pre-screening behind the scene, or pre-filtering, I guess is the better word I should use, behind the scenes to get that data to the TPA. We don't get to see all their claims. And they also mask their reimbursement rates as well, because they don't want the outside to see what they're being reimbursed. They also don't give us the full usual and customary either. They use what's called a reference price, and that's how the net value of a specialty claim is created. Is usually typically some form of a whack float, whack minus. So we've been using that AWP as well for the specialty pharmacies because the data is just not there, and we felt like that was the closest proxy that we can get. And then it does give the consistency as well across the whole platform if we don't have usual and customary.
We have to do something similar with the entity-owned data sometimes when you're doing a cash price because you don't necessarily have usual and customary if you're uninsured and underinsured patients. So sometimes we'll use that AWP as a surrogate marker, which tends to work pretty well.
And we've also got baked into the report as well. So if you're using our Verity Care Card, which is our solution for extending the sliding scale at the point of sale, when that bin, PCN, and group combo comes over, we're actually able to allocate that in the UDS report to sliding scale as well. So it does automate some of that. And it is processed through a PBM, so it's real switch data. So again, we're going to have the usual and customary that comes over, and you'll see even for if it's a split billing. So if maybe Medicare is the primary, and then we COB it to the Verity Care Card, the patient out of pocket is going to be determined on that last payer. So it's a true patient out of pocket, not aggregating both payers together.
Yeah, and that's complicated when you have primary and secondary billing that you've got to figure out what that true out of pocket is, not.
And even more complicated at a health center with limited staff and resources and people that don't necessarily know down into the weeds of those.
Because a lot of times you don't have a 340B staff in a health center, so you've got a billing manager trying to figure it out as they go, and it's challenging.
So with that said, kind of parting words of advice for health centers trying to navigate if they have not previously delved into how they're reporting pharmacy and 340B information for their UDS. Aside from definitely talk to your TPAs, talk to your vendors, see what resources they have in terms of being able to provide that information, but what can they do kind of internally?
Yeah. I mean, I would say consistency matters, right? So if you are submitting one whack float price from one vendor and then an extremely different whack float price from another TPA, right? That's going to create an error. So, you don't have, that's again why we provide that raw data in our reports. You don't have to use our number. You can use whatever proxy, you feel comfortable with for consistency. So I would urge that. And I would also urge, give us feedback, right? We've got a lot of seasoned professionals. But sometimes I feel like even myself, I mean, it's been 5 years since I've been out of the covered entity, and lots changed since then. So we really need our customers' feedback. So don't be shy about it. Pressure test the reports. If something seems off, I think you both can attest to this. We identified some issues in our UDS report, and we put development work in to get it updated for this coming year. So we're only as good as the feedback we get from our customers. And I think that's really important as we go on to make sure there's consistency.
I think from my perspective, it's timing is it's a really short time frame from until the February 15th when they're due. So it's important that you start that communication early, especially this year going into the Inflation Reduction Act. It's going to be a little crazy at the first of the year. So it's important that we're having those communications early with your TPA partners, so you're getting that prepped. And if you have an entity-owned pharmacy that's not managed by a TPA, make sure that they're ready to run your data as well.
Or, I mean, there are some health centers that use a contract pharmacy with a local independent that don't run that through a TPA either, and that would be a unique scenario. Also, I know that the reports from the different TPAs aren't all available at the same time. So helpful to know, by the end of this year, speaking to each of your TPAs, when can we get this report to be able to work on this? And that way you can kind of tier your preparation efforts so that you're not waiting until the last one's available to do all the work. You can kind of address them as they become
And
available.
not spending Valentine's night away from your partner finishing your UDS
Yes,
report.
yep. I think the last thing I'd think of is if you've not spent time within the organization delving into this, partner up with, a finance person, a pharmacy person, if you have a 340B person, that as well, and a data person, however your organization addresses that, so that you can review that and delve into it all together to make sure that you are pulling the correct data for those if you've not done that deep dive before.
And I think that's one of the beauties of all the conferences we have, right? We've got, great NAC conferences, grantee conferences, the 340B Coalition. And really, I think not even so much as the session content that comes out of that, but for me, it's always been like, the conversations in the hallway. Really get to know people and like, how are you doing this?
Your
right?
phone a friend.
Exactly.
Yeah.
Yep.
Awesome. Well, thank you so much for joining
Yeah,
us
of
today,
course.
Matt.
It's
Really
been-
appreciate your insights.
It's been great being here. Thank you.
Thank you.
Thanks.